Well, thank you, everybody, for attending the presentation. There's kind of a pressure to be first. I'm Anna Forsythe. I'm a founder of Oncoscope-AI, and I'm here to talk about our real-time oncology evidence library. I'm sure you all know there's a lot of publications in oncology. I've read recently from ChatGPT that oncology evidence doubles completely every 6 months. I totally believe it could be possible. Did not have time to check that. But we do know how many abstracts, posters are always at these conferences, and these are important because we could save someone's life with that new evidence. The best way to learn about the new evidence is to conduct systematic literature review. However, the time is enormous that is required, the efforts, the money, and simply physicians do not have the time to keep up with all that evidence. So I thought, why don't we create something like Expedia for oncology, reliable, up-to-date, easy to use, no training required, no download required. So a team of experienced researchers every day starts their day with conducting an update for the literature review for every single tumor type, by tumor type. They run a system, it's our proprietary system of AI models as well as automation that reviews according to our protocol. The protocols are published on Prospero, and then extracts 32 variables from every single publication. Then we integrate that publication with others for the same trials, link it back to original sources, and give it for free to every single verified healthcare professional, does not matter where you are. We extract variables that contain patients' characteristics, that contain intervention and comparator, the outcomes that the trial is reported, as well as study design. And most importantly, we integrate every single study within the clinical pathways of national guidelines, US and European. We make sure that we understand whether that specific treatment in that specific subpopulation has been approved by FDA or EMA or not. We look at clinical trial registration and clinicaltrials.gov. In case the study may be still ongoing, you may consider that study. We link it back to PubMed or to the Congress presentations, because we do review all Congress presentations in real time. The day the Congress releases that presentation, that's the day you're going to get that. We have a proprietary system, as I mentioned. It is an agentic AI system of more than 30 different models, as well as automation steps that we apply to our protocol review of each publication, as well as extraction. We do not offer you software to conduct SLR. We offer you a library, a resultant database that is updated daily. You have other sources, of course. Many of you use up-to-date. But is it really up-to-date or up-to-month or up to a year? If you are attending a conference, are these conference presentations on there already? And by the way, although it is conducted by experts and is a very reliable and comprehensive source, it is not a systematic literature review that you can print a report and then reference in your submissions to New England Journal of Medicine, or your regulatory submissions, or your reimbursement submission. They're chat bots. They are wonderful. You can talk to them. But have you ever wondered why there is no chatbot for Expedia for you to book travel? Because you have too many questions. Do you want an aisle seat or a window seat and all of that? Well, maybe that is why there shouldn't be a chatbot when you have a patient in front of you, because there are many questions and you want to make sure they are answered correctly and your reference is reliable. And you, by the way, don't have to spend time to look for that reference. The data is in front of you. We have one database and we offer 3 products. 2 are free, for healthcare professionals, for physicians. We launched at ASCO this year our essential tool for community oncologists, and later, upon request from many oncologists like you, we launched another free tool, the Edge, that is for researchers, for your experts in the field. And yesterday at ESMO, we launched the enterprise version for pharma, which I'm not presenting here today. And now, of course, the best thing is to see. When you log into a cancer, and here I am to show you non-small cell lung cancer, all you have to do is look at the disease map. This is your populations and subpopulations. So you just start selecting a clinical stage, a biomarker, and maybe a treatment path, and then an intervention category. You build in the treatment path that is consistent with the guideline. You want to know what specific therapies they are in that treatment path, and you see them. And you will see whether they are approved or recommended. But what if you don't have that specific patient in front of you? You just want to learn ADCs. ADCs are everywhere right now, and I've been at one continuing education session. I remember a podium speaker said, well, I don't even know how many studies there are currently with ADCs in lung cancer. Well, I could tell you how many, 54. It's right there in the right top corner. 54 studies of ADCs in non-small cell. Well, how many of them are in metastatic? Well, 53. That's how fast you are. And maybe at this point, you don't need to select more variables. Maybe you just want to look at all 53 studies. Hard to process all 53, but you could explore the database in real time. So now, you don't need training. It looks just like PubMed, except in difference to PubMed, your references and your sources are all linked. So if there is a label, it is linked right there. And by the way, if it's more than one publication, Destiny 2, along 2, busy study, more than one, there's always a main publication, but then there could be more. And you could see where they were presented, whether it was an abstract, whether it was an additional, and was it a follow-up analysis, quality of life analysis, subgroup analysis. It's easy for you to find. We extract the variables, as I said, as you could see here. If OS would have been reported, it would have been there. But what if you want to add variables? What if you want to know, for example, whether the study reported quality of life? All you have to do is click right here, and the quality of life would be presented right there, because yes, we pre-extract for you to save you the time. You can organize your publications by date. Right now they're organized by relevance, so those that are approved and recommended will be right there on top. You also can add additional filters, and that is a cool feature. For example, if you're preparing for a tumor board and you want to know all the patients, for example, with brain metastases, you could select them here. Or, that was the most recent addition, I was told, hey, you load all of the conference abstracts, but I just want to look at that conference because we upload before the conference starts, after they release the abstracts, obviously. And sometimes you're going to that conference and you just want to find that abstract, and where is that? So you could now filter by conference. So if I want to know how many presentations on ADC were at ESMO, which just happened, 11. I could tell you where they are, and you could see which studies and what was presented. So it is actually as simple as that. But what if you want to remember it tomorrow? What if you want to print this out to add, to support your, if you're in US, prior authorization request? So simple. You just select that study and you say, well, I just want to download that. Select it. And the report would go to your download file. It would tell you who you are, you logged in, which date, what were the criteria of the systematic literature you've reviewed, you applied, and then it shows you the criteria, the actual variables that you selected to show, and all the references are still here, still linked, still intact, so you could still check the references. We're a new company. we launched at ASCO this year. We have breast cancer, non-small cell lung, and prostate. Did I mention it's free? All of you could sign up. We have a booth right there. We're launching myeloma in the next 2 weeks because ASH is coming, and we're going to collaborate with several organizations in the United States that want to give it to more physicians and even patients advocates. And then we're launching bladder right before Christmas and already starting on our schedule for next year. That is all I have. Questions? Oh my God, I have a lot of time for questions. Sorry. Thank you. Questions? Yes, please.
Hi, can you hear me?
Yes.
So, Mikhail from Johnson & Johnson. My question is actually about the copyrights. How do you go about the copyrights? Because it seems you are uploading the conference abstracts to a data set. Do you get permission from the societies? Do you have agreements with them?
Everything that you see in the physician version that is free is done based on abstracts. And the abstracts are okay to do because they eventually appear on PubMed or on public databases. All the information you see here is based on the abstracts. And according to the PubMed copyrights, you can link, as long as you link it back, that's why you're linking back to PubMed and not to original PDF. We can talk separately. There is a version for pharma that is not free, where there are full texts and the copyrights are obtained on behalf of each specific subscriber.
Thank you.
Any other questions? Thank you.
Stefan Glück, Professor Emeritus from University of Miami. Can I use it for my patients real time? Or do I need to be prepared the evening before, and the morning before I see, let's say, a patient with complicated non-small cell lung cancer, because this is what you have, some mutations, some driver mutations are present, and the patient already had a number of compounds, and the compounds failed.
Right. No, it takes about 30 seconds, or 3 clicks. It's between 3 and maximum 6 clicks to see all the relevant therapies. And as I said, the therapies are organized in relevance order, which means right there on top would be what is recommended and approved. If there is nothing recommended and approved, if there is nothing, we have a category, we call it Oncoscope radar. Now, what is that? This is for the clinical trials in pivotal stage that already presented positive results, but then there's also investigational. And these are linked, as I mentioned, to clinicaltrials.gov, so you can always find the study also to potentially enroll your patients.
Thank you very much.
Hi,
Yes.
I'm Eamon Sebtain. I'm an oncologist from London. Congratulations, it looks absolutely fantastic. I can't wait to use it. How come it's free?
I spent my life in the pharmaceutical industry, and I'm lucky I was able to make more money than I feel I need. And I have friends. Once some of us reach a certain age, you always have a friend or a relative that has a cancer. And I was very frustrated that there is no resource, not only for patients, but for physicians. And then the guidelines are so difficult and convoluted and not even often up to date. And physicians see 30 to 50 patients sometimes a day, and who has time? So I have decided to spend my savings to do this, and if I could save a life of 1 or 2, that would be great. And for those of you who worry for my financial being, because I know some of you do, really, as I've mentioned, there is a version for pharmaceutical industry, and no, it is not free. It has a lot more information and a lot more resources, but it is no longer free. So pharma pays for us to give it for free to every doctor, and it is not temporary. it will always be free.
Hello, Dr. Hayrath from Peter MacCallum Cancer Centre in Australia. Congratulations on your work. Very exciting. Are you planning to, or have you performed any evaluation of accuracy of your system?
Absolutely. We had two abstracts at ASCO. One was on the validation of the system, and the second, there were two anyway. We have a poster here, right here. I highly recommend you look. I believe it's 281. And what we did is we evaluated our system on relevant clinical questions. We work with leading physicians for each cancer to establish the system. It does take us about 2 months to establish a cancer because we work very closely with the physician, plus we have to run SLR back to the dinosaur years, as I call it. And we validated, we're presenting here a comparison to chatbots. Unfortunate for chatbots, I have to say. Okay, and we have performed, yes, it is two separate validations. There's a validation of whether AI can review and extract. And by the way, our AI reviewer has less than 1% false negative, less than 1%. AI extractor, no. There are some variables that AI is 100%. And there are some variables like subgroups that I'm sorry to say, I don't know if AI will ever get. AI gets confused with subgroups or complicated questions. That is why nothing from AI goes to you. We don't want to have a chance of even less than 1% mistake. We have a team of PhDs with at least 10 years in conducting research in oncology that verify and QC every single variable 100%. I have 3 minutes. Well, thank you very much. I give time to the next presenter. The booth is over there. Please come. It's free. Thank you.